Welcome everyone. Today we're going to discuss this concept of embolic stroke in a little bit more detail again, with some exciting discussion of future directions in both research and the way that we diagnose stroke. Once again, I'm Dr. Michelle Johansen. I'm an assistant professor of neurology at Johns Hopkins. This is an area that I do research in, and I'm excited to be able to share it with you today. This is one of my favorite quotes from Shakespeare, "'Tis but thy name that is my enemy." It was in Romeo and Juliet. And essentially what I'm getting at here is that it's easy sometimes as physicians for us to put a label on things and not really think about what it is that we're labeling. So we want to be cautious when we give our patients a diagnosis that we're not just labeling them with an incorrect label, because it's an easy thing to do. So what do I mean by that? Well, let's start once again by reviewing this idea of cryptogenic stroke versus ESUS. Cryptogenic stroke I introduced in the last lecture, and it includes those patients for which we do not know the cause of the stroke. It can come from multiple different reasons, one being they never had testing performed. That's fair. We don't know the cause of the stroke. The second is they never completed a stroke workup. And the third is they had two competing etiologies for the stroke. That's a classic TOAST definition of cryptogenic stroke. ESUS, on the other hand, which I introduced in the last lecture, this embolic stroke of unknown source, is thought to be a subset of cryptogenic stroke. It requires a minimal threshold of testing, and it's classically defined as a non-lacunar stroke where the etiology is unknown. So people will ask me, well, how common is this cryptogenic stroke where we don't really know the cause of the stroke? It's actually more common than we care to admit. Now, granted, this is in North America and European studies. We're not quite sure over in other countries the percentage of cryptogenic stroke, but we're excited to be collaborating with you as we work to take care of these patients. But at least in the North America and European studies, it accounts for up to a fourth of the patients that we take care of. This is a wonderful diagram, and I've included the reference here below if you're interested in reading more about this, that summarizes these three important concepts that I've been trying to communicate to you today and in the prior lecture about cryptogenic stroke, cardioembolic stroke, and then this embolic stroke of undetermined source or unknown source. So cardioembolic stroke, what's an example of that? Well, we discussed that in the last lecture. It essentially means that you have a typical clinical and neuroimaging profile, a high-risk cardiac source, and absence of large artery stenosis. Makes sense. That's the definition of a cardioembolic stroke. Okay, what's an example of a cryptogenic stroke? Well, once again, that's where we don't really know what the cause of the stroke was. So an example might be carotid artery stenosis not detected due to an incomplete evaluation. Remember those patients who didn't get a full evaluation? If they never got imaging of their carotid arteries, we don't know that. That goes in that cryptogenic stroke bucket. Now, embolic stroke of undetermined source is exciting because let's say the patient only had paroxysmal atrial fibrillation that lasted only a few minutes. Is that enough? Is that sufficient to form a clot? Should that patient be treated like a cardioembolic stroke patient? They're not currently, and we'll talk about that more in some detail. And then there's this overlapping area here. It could be cardioembolic and cryptogenic overlap, and that it's a high-risk cardiac source that's not detected due to an incomplete evaluation again. If the patient had been tested, we would know it was a cardioembolic source. And then here in the center of all of this is this idea of a thrombogenic atrial substrate in the absence of atrial fibrillation. And this was a concept that I alluded to last time. Is there something abnormal about the left atrium that we essentially haven't diagnosed yet and that we're not quite sure what to do about, but the patient doesn't have atrial fibrillation after prolonged monitoring? So ESUS, what do we do for these ESUS patients? How do we diagnose these ESUS patients? Well, for now, we do what is classic when we do an embolic stroke workup. A 12-lead EKG, for example, 24 hours of telemetry to assess for atrial fibrillation, vascular imaging of the head and neck. Certainly want to consider the vessels and don't leave those out. An echocardiogram, the guidelines have gone back and forth on this, but it is routine in most places to do an echocardiogram, and it can be a very powerful tool in my opinion. An additional test may be appropriate depending on the patient population. For example, looking for rarer causes of what could cause an emboli. So the proposed criteria for ESUS right now as it stands is stroke detected by a CT or MRI that is not lacunar. Once again, we're not talking about small vessel disease here. It's absence of extracranial or intracranial atherosclerotic disease causing greater than 50% luminal stenosis in arteries supplying the area of ischemia. So what did that sentence essentially say? Basically, it's not large artery disease. It's not lacunar, it's not large artery disease. There's no major risk cardioembolic source of embolism. So at least one that we know of on that list, either high risk or medium risk, they don't have that. And there's no other specific cause of stroke identified. They don't have an arteritis, they don't have a dissection, they don't have a migraine, there's no vasospasm, and the patient isn't using drugs. So this is a proposed criteria for this concept of ESUS. So what does the research tell us about these ESUS patients? Well, there was a large systemic review that was done, and it showed that the mean age of these patients, 65 years old. Okay, that's a little bit younger than what we normally think of as far as stroke patients. It was 42% women. There was a lower frequency of conventional vascular risk factors. Interesting. And the average NIH stroke scale was 5. So these patients certainly had strokes. They were certainly devastating, but not very high NIH stroke scale strokes. So they presented with more milder symptoms in general. Now, ESUS can recur. The annualized recurrent stroke rates average 4.5% per year during a mean follow-up of 2.7 years. That's interesting. And of course, these patients, as of now, are treated with antiplatelet medications, right? Unless a patient has a cardioembolic source that we have evidence for using anticoagulation in, all other patients are currently treated with antiplatelet medications. Is that appropriate? We'll talk about that in a moment. So ESUS patients and stroke recurrence, this is a wonderful study that speaks more about this in case you're interested. Most recurrent strokes after ESUS were embolic and of undetermined source. Recurrences with atrial fibrillation was low. So people will ask me, for example, Dr. Johansen, is it possible that these patients just weren't monitored for long enough? Well, this cohort monitored these patients and found that ESUS patients who recurred, if they did manifest atrial fibrillation and it hadn't been captured before, it was pretty low, only about 9%. So maybe there's something different about this group. The recurrent strokes were more likely to be hemispheric strokes, left greater than right, rather than in the brain stem or in the cerebellum. Also makes sense. An embolic shower tends to go more to the hemisphere than brain stem or cerebellum. So this left atrial myopathy or atrial cardiopathy or left atrial cardiopathy concept has become now more and more developed since 2014 in the emergence of this ESUS idea. And it's something that I use in my research as well as many others across the United States. Essentially, the definition is changes in left atrial structure and function that are independent of a development of a tachyarrhythmia. So once again, we're not talking about atrial fibrillation, right? We know what to do with atrial fibrillation patients. This is something different, changes in the left atrium that are sufficient to result in an embolic stroke. So how do we think about the left atrium and what are ways that we can characterize the left atrium? So this is just some exciting work that's been ongoing, and this is a very nice picture from Circulation that summarizes this as far as different ways that we can think about how we can analyze the function of the left atrium. So for example, you could do a flow MRI. So looking at the way that the blood flows through the heart, it may be that that's abnormal, even though the patient has not developed atrial fibrillation. It could also be maybe to use MRI, and there's been evidence to show this, and you can do a fibrosis map looking for scarring on the left atrium. You can also do what's called surface EKG. Of course, you're familiar with that. Targeting the atrium, however, to see whether or not there's something different about the atrium, so more specific investigation of the atrium. And then speckle tracking strain, which is something I use in my own research, and I'll show you some videos, that looks at the way that the left atrium is stretched or stretch on the left atrium. So this is what I was referring to. These are videos from my research patients specifically. And I show them to you today just to give you an idea of what we're talking about when we're thinking about how we can analyze the left atrium in stroke research. So for example, this is your typical echocardiogram that's looking at the way that the left atrium is functioning. And I have the walls drawn here. Now you can take that information and you can make maps and divide it up into segments and look at the way that the atrium is stretching. And then from there, you can look at it in three-dimensional views. You can look at it from all different ways to see what this particular echo method is telling you about the way that the left atrium is moving in space. And we found some associations with the way that the left atrium is moving in space and the type of stroke that the patient has, which is really fascinating. So let's talk about that a little bit. So what do we know about left atrium and stroke? Well, we know that left atrium, if it's enlarged, is an independent marker of recurrent cardioembolic or cryptogenic stroke. So these patients didn't have atrial fibrillation, their left atriums were big, and they had an association with a recurrent stroke, specifically either those that were cardioembolic or we just didn't know the cause yet. Electrocardiogram left atrial abnormalities were associated with vascular brain injury in the absence of atrial fibrillation. So patients who have a rapid heart rate are known to have more findings on their brain MRIs than those that don't. But isn't it interesting that in patients who did not have atrial fibrillation, an enlarged left atrium was enough to see these similar changes on brain MRI? Mean P-wave terminal force in V1, which is just a specific marker, as many of you know, of the way that the left atrium is functioning, was associated with cryptogenic or cardioembolic stroke independent of atrial fibrillation. And then finally, a PR interval of greater than 200 milliseconds, once again, more information about the way that the heart is functioning, was associated with a cryptogenic stroke, once again, in the absence of atrial fibrillation. So these are all hints that there's something that's going on in this patient that's sitting in front of you. That doesn't necessarily mean they absolutely need atrial fibrillation to have a stroke. Left atrial appendage is probably something that you've read about or maybe heard about, and morphologies of the left atrial appendage have different associations with stroke subtypes. So there's classically 4 different types of left atrial appendage that can be described. This is the cactus, classically called. This is windsock here. This is the cauliflower shape. And then finally, we have the chicken wing here. These are sort of funny names to say, but essentially what it was they took the appendage, this is actual pathology here from a heart, and they looked at the shape of the appendage, and they looked at the blood flow in this particular part of the left atrium, and they said, what's the stroke risk between all of these? And it was interesting that it was different. And then finally, cardiac MRI, I just bring this up in case you encounter this in the literature or if you've heard about this before. Cardiac MRI can identify fibrosis, and it was more common in patients with ESUS without atrial fibrillation. So once again, just continuing the story of there's something interesting that's going on in the left atrium. It doesn't necessarily have to manifest as atrial fibrillation. All right, so let's move back into this concept of ESUS again. I spoke about this idea of an atrial myopathy or an atrial cardiopathy, and that falls under this group that may have ESUS or an embolic stroke of unknown source. So how do you treat these patients? Well, currently, antiplatelet agents are the standard of care. That's what we do. We give patients aspirin. We give patients another antiplatelet agent. There's no evidence currently that we should be doing anything else differently. However, the question was raised and continues to be raised. Should ESUS patients be treated with anticoagulation? So this was proposed originally in this 2014 editorial that I showed you all previously. And it's interesting because they postulate that ESUS patients could have cardiac abnormalities and therefore occult sources of thromboembolism. This embolization consists of thrombus, once again, that concept of red thrombus, and therefore anticoagulation would be preferred to antiplatelet therapy. Interesting concept. Once again, no evidence for this, but something that I think will rapidly develop in the years to come. So there were some studies that I'll bring up for you to know. One was the rivaroxaban for stroke prevention after embolic stroke of undetermined source, or the Navigate ESUS study. And essentially what they did was they took this group of embolic stroke of undetermined source and they randomized them to either receiving rivaroxaban, which we know is an anticoagulant, right? Or aspirin, which is an antiplatelet. And they compared them to see whether or not they could prevent recurrent stroke. And their conclusion was that rivaroxaban was not superior to aspirin with regard to the prevention of recurrent stroke after an initial ESUS stroke, and unfortunately was associated with a higher risk of bleeding. So that was using rivaroxaban. Well, dabigatran is another medicine that can be used, right? Once again, in atrial fibrillation, for example. So they took dabigatran and did the same thing that rivaroxaban did and randomized patients, either dabigatran or aspirin, if they had ESUS, to see whether or not they could prevent a recurrent stroke. And once again, they didn't show that either. And it was also associated with a higher risk of bleeding. Okay, so what do we conclude from that? Well, we have now 2 large clinical trials that showed no benefit in anticoagulation therapy in preventing recurrent strokes after ESUS. Okay, but remember that there are disease processes that should respond to anticoagulation and those that should not. So we spoke about occult AF. We spoke about maybe this concept of atrial cardiopathy as being things that might be treated with anticoagulation. However, we all know that hard white thrombus plaques, for example, from a large artery stroke, those don't benefit from anticoagulation. We've known that for quite a while. So I would propose that ESUS cannot be considered a single entity, and that may be why there was no difference seen in these trials, is because they lumped these groups together. So now that I've whetted your appetite for this idea of embolic stroke, and we spoke last time about atrial fibrillation, how important it is, how you should treat those patients appropriately. We spoke about cardioembolic stroke. I introduced this concept of cryptogenic stroke, where we just don't know. And now this exciting idea of ESUS, whereby maybe there are ways that we can start to diagnose these patients a little bit better and treat them more appropriately. So in closing, I'll just go through some of the future directions and trials that are ongoing that you'll see come out in the next year, 2, 3, or 5 that give us more information about where the field is moving. So I'll start with the Arcadia trial, and I should disclose that I adjudicate for this trial. And essentially what the Arcadia trial does is it uses this concept of atrial cardiopathy, that atrial myopathy I was alluding to before. It's a phase 3 clinical trial of apixaban versus aspirin. And it is defining a group of patients of having atrial cardiopathy. And they specify here either P-wave terminal force or left atrial size or serum NT-proBNP. So we're saying if we can identify a group of patients that have atrial cardiopathy and give them apixaban versus aspirin, maybe we're singling out a group that would actually benefit from anticoagulation. And that's the hypothesis, is that apixaban would be superior to aspirin for the prevention of recurrent strokes in subjects with cryptogenic ischemic stroke and atrial cardiopathy. Okay, now what about multiple cardiac abnormalities? We alluded to this in the prior lecture, whereby there are those things that are high risk, there are things that are medium risk, and there are things that are low risk. What happens if you have more than one? In medicine, not infrequently, we see patients who have a little bit of this, and a little bit of this, and a little bit of this. Is there an additive effect that then leads to emboli? So there's an Atticus trial that's ongoing that's using apixaban to look at ESUS patients. And the hypothesis is that apixaban administered within 7 days after ESUS is superior to aspirin for preventing new ischemic lesions. And they're defining these multiple cardiac abnormalities in the following way: left atrial size, spontaneous echo contrast, flow in the left atrium, maybe they have high rate episodes, maybe they have a persistent foraminal valley, Maybe their CHADS-2 VAS score suggests that they have increased vascular risk. So this will be an interesting trial and should come out in the next year or two. Now, what about short subclinical atrial fibrillation, right? So anytime you monitor a patient, you have to decide what it is you're going to do with the information. Similar to testing any other thing in medicine. If you're going to get a test, what do you do with the information? So if you put in an implantable loop recorder and your patient has 1 second of atrial fibrillation, does that mean anything? What if they only have 1 second over 5 years, for example? An extreme example, but should you treat that patient? There's 2 trials that are ongoing. The first is the Artesia trial, which is using apixaban again for the reduction of thromboembolism in patients with device-detected subclinical atrial fibrillation. So they have to have at least 1 episode of device-detected subclinical AF, but no episodes that are longer than 24 hours. So they're really trying to get at the short subclinical AF patients, and they're going to see if anticoagulating those patients makes a difference. This is another one that's ongoing called the NOAA trial, and it's similar, but it's looking at atrial high rate episodes. So for example, patients who don't necessarily have atrial fibrillation, but their atrium is beating at a very rapid rate. Should those patients be anticoagulated? So they're going to compare edoxaban to no anticoagulation versus aspirin, and they're going to follow those patients for stroke and cardiovascular death. Now, what about malignancy? This is an idea that we kind of teased out before. It's different than the left atrium. It's different than whether or not your patient has atrial fibrillation and if it lasts, however long it lasts. We know that patients who have cancer are at increased risk for throwing clots to the brain. Is it possible that maybe there's an occult malignancy that's caused an embolic stroke? Or is there a difference in the way that we should be treating patients who have cancer to prevent development of an embolic stroke? This trial is ongoing and just recently closed, and it was the enoxaparin versus aspirin in patients with cancer and ischemic stroke, or the TEACH pilot randomized clinical trial. And it took patients who had malignancy, and they had a confirmed acute ischemic stroke within 4 weeks. And they randomized them to enoxaparin, right, which is a heparin-based agent, versus aspirin. But unfortunately, they failed to enroll the whole population because there was an aversion to receiving the injections, and many of their patients crossed over to aspirin. So while this study is not conclusive due to enrollment failure, it's interesting, tantalizing maybe, to suggest that a future direction would be to look at patients who have cancer to see what their risk of stroke is and whether or not those patients should be treated differently than what we currently do. So final conclusions from both this lecture and the prior lecture. Embolic strokes can be devastating, and cardioembolic stroke patients in particular have poorer outcomes than other stroke subtypes. Different clot materials can embolize, and treatment strategies should incorporate patient characteristics and clot pathology. And then finally, ESUS is an important new concept and represents an exciting field of stroke research. So I look forward to meeting with you and to answering all of your questions about both this lecture and the preceding one.